Good morning, Dr. Phil here. Today we'll be discussing on gas embolism. Definition. Gas embolism occurs when there is introduction of gas into the vascular system, resulting in a spectrum of clinical effects, ranging from asymptomatic patient to shortness of breath to cardiovascular collapse. Pathophysiology. Venous gas embolism is more common than arterial gas embolism and is the result of entrainment of air into the venous circulation. For a gas to be admitted into the venous system, there must be a source of gas, a communication between the gas source and the venous system, and a pressure gradient enabling entrainment of gas. Air entering the venous system reaches the right atrium and the right ventricle, causing pathological effects via heart failure, pulmonary edema, and paradoxical gas embolism. In heart failure, airlock occurs. A bolus gas embolism results in compressible air obstructing the right ventricular ejection at the level of the pulmonary outflow tract. Gas in the heart is compressed with each beat and not expelled. Foaming and interruption of blood flow occurs, and there is a reduction in cardiac output. When there is a slower infusion of venous gas embolism, air is trapped at the level of the pulmonary arterioles. This increases pulmonary vascular resistance, increases right ventricular afterload, right ventricular failure occurs, and this reduces left ventricular output. In pulmonary edema, microbubbles in the pulmonary arterioles causes neutrophils to be attracted to the fibrin, RBCs, fat globules, and platelets built up around the bubbles, causing tissue damage and pulmonary edema. Paradoxical gas embolism can occur via patent foramen ovale or transpulmonary gas shunting. Increased pressure build-up on the right side of the heart causes gas to be pushed through the pulmonary circulation into the left atrium. Air emboli in the pulmonary vascular bed reaches the systemic circulation. Increased pulmonary arterial pressure favors the transfer of air into the arterial circulation. Eventual outcomes are affected by the rate of gas entrainment, volume of entrained gas in relation to body size, position of the patient at the time of venous gas embolism, and whether paradoxical gas embolism has occurred. The greater the rate of gas entrainment, the smaller the lethal volume. Symptoms or signs of an gas embolism appears following 0.5 ml per kg per minute of intravascular gas. The slower the rate of gas entrainment, the better tolerated venous gas embolism is, as gas has time to be reabsorbed. The volume of entrained gas to cause significant injury in adults is unknown and has been estimated to be 1 to 5 ml per kg. The effect of VGE in children is more than adults, as a given volume of gas will be a larger proportion of the ventricular volume. Arterial gas embolism. Gas may enter the arterial system indirectly from paradoxical gas emboli or directly, for example, from flushing of bubbles into arterial lines, in cardiac surgery, cardiopulmonary bypass, angiography, carotid endarterectomy, laparoscopy, and decompression sickness. Arterial gas embolism may obstruct the coronary or cerebral vessels. Small volumes of gas are usually well tolerated by most organs. However, the heart and the brain have high metabolic requirements. Arterial gas emboli in the heart or the brain results in end-arteriolar obstruction, distal hypoperfusion, hypoxia, cellular damage, tissue edema, and worsened oxygenation. Risk factors for gas embolism. For venous gas embolism, the patient, spontaneous ventilation results in negative CVP. Anesthesia, operation site higher than the heart, causing atmospheric pressure to exceed venous pressure. Any open vascular access point, air within IV administration sets. Procedures involving insufflation or injection of gas, such as in epidural anesthesia using loss of resistance to air, positive pressure ventilation, hypovolemia, during CVL insertion, disconnection or removal, and pressurized infusions. Surgery. Neurosurgery, during craniotomy, risk is maximal in the sitting position, such as in posterior fossa operations in the sitting position. Incidence of VGE is up to 100% during a seated craniotomy. VGE is more common if the venous sinuses are open with the head elevated above the level of the heart, as dural sinuses do not collapse. VGE has also been reported during supine infratentorial intracranial surgery. Spinal surgery. The frequency of VGE in the prone position has been measured to be 1.7% in one study reviewing 120 neurosurgical operations. However, at present, the true incidence is unknown. Efforts to minimize abdominal compression and thus IVC pressure in the prone position results in increased negative pressure gradient between the right atrium and veins at the operation site, increasing the risk of gas entrainment. Orthopedic surgery, such as arthroplasty, arthrography, and long bone surgery, especially intramedullary nailing and hip surgery. In obstetrics and gynecology, caesarean section, termination of pregnancy, removal of placenta and hysterectomy. In ENT surgery, such as middle ear procedures and laser procedures involving gas-cooled probes. During general surgery, such as in laparoscopic procedures, endoscopy, neck surgery, and vascular surgery. Oxygen embolism has been reported during the use of hydrogen peroxide as a hemostatic agent. Arterial gas embolism. Gas can enter into the arterial system either directly or indirectly, which has been discussed in the previous section. Presentation. Venous gas embolism. In most cases, VGE is unexpected. Presentation depends on the rate and volume of gas entrained and ranges from clinically silent to potentially fatal. In an awake patient, rapid gas entrainment results in apnea, signs of hypoxia, and shock. With slower gas entrainment, there is dizziness, dyspnea, chest pain, sense of impending death, gas reflex, signs of hypoxia, and shock. Cardiovascular system. The heart rate may increase, there may be a loss of palpable pulse, there may be hypotension, auscultation. The use of stethoscope to identify mill wheel murmur is no longer used due to lack of sensitivity. ECG. Right ventricular strain pattern, ST segment and T wave changes, tachyarrhythmias, AV block, PEA and cardiac arrest may be seen. Precordial Doppler probe is effective for detecting larger emboli, 0.2 mL per kg. Transesophageal echocardiography, positioned to obtain a 2D 4-chamber view of the heart to detect both VGE and PAE, is the most sensitive method to diagnose VGE and can detect a bolus of gas of 0.02 mL per kg. However, TOE is not always practical due to various reasons discussed later. CVP. There may be increased CVP due to reduced cardiac output and increased pulmonary vascular resistance. CVP may then decrease. Pulmonary artery catheter. VGE causes increased pulmonary artery pressure. Respiratory system. There may be cyanosis, tachypnea, apnea, desaturation, bronchospasm, signs of pulmonary edema. EtCO2 may decrease due to increased dead space, increased intrapulmonary shunting, and reduced cardiac output. Reduction of 2 mmHg may indicate VAE, however this is not specific. EtCO2 may also decrease by concomitant hypotension. ABG may show decreased PaO2. Increased PaCO2 may be present. Chest X-ray may be normal initially. Signs of pulmonary edema may develop. CNS. There may be a drop in GCS with neurological deficits. Presentation of arterial gas embolism. Presence of gas in the coronary arteries may present with anginal chest pain, hypotension, dysrhythmias, myocardial depression, ventricular failure, cardiac arrest, cardiogenic shock. ECG may show ischemia and infarction. Presence of gas in the cerebral arteries. Presentation depends on the volume and location of the gas emboli. Onset is rapid, with headache, confusion, motor weakness, disorientation, hemiparesis, convulsions, loss of consciousness, coma, asymmetrical pupils. Impairment of brainstem centers may result in abnormal respiration, arrhythmias, and shock. Delayed awakening from general anesthesia. Gas bubbles may be seen during retina examination. CT MRI brain may show intracerebral air, hypodense lesions, and cerebral infarction. Paradoxical gas embolism presents with both signs of venous and arterial gas embolism. Differential diagnosis for gas embolism includes pulmonary thromboembolism, pneumothorax, bronchospasm, hypovolemia, septic shock, other causes of hypotension, pulmonary edema or cardiogenic shock, brainstem retraction or ischemia, fat embolism, amniotic fluid embolism, and entrainment of gas into respiratory gas analyzer. Prevention of gas embolism preoperatively. At-risk patients should be identified preoperatively. Kindly refer to the risk factors section discussed previously. Employ preventive measures and employ appropriate monitoring for gas embolism in these patients. Patients with a patent foramen ovale should ideally not be subjected to known procedures associated with a significant risk of venous gas embolism. Pre-op screening for PFO should be considered for patients scheduled for procedures associated with a significant risk of venous gas embolism. Intraoperatively, the negative pressure gradient should be kept to a minimum by reducing the height between the operative site and the right atrium. Increase right atrial and central venous pressure as long as the patient's cardiac status permits, such as by using IV fluids, jugular venous compression during high-risk periods, the usage of PEEP, and the usage of anti-gravity suit. However, note that PEEP may increase the right atrial pressure exceeding left atrial pressure, which risks paradoxical gas emboli when PFO is present. For anti-gravity suit, consider during neurosurgery in the traditional sitting position. A modified sitting position with legs placed horizontally may reduce VGE. Hemostasis intra-op should be meticulous. The venous circulation should not be left open to atmospheric pressure. However, if left open to atmospheric pressure, it should be for the shortest time period possible. Throughout the surgery, good communication between all relevant OT staff, IV catheters and fluid administration sets should be free from gas bubbles. Apply suitable occlusive dressings. The CVL site should be below the level of the heart when inserting or removing CVL to cause the venous pressure at the CVL site exceeding right atrial pressure. Monitoring methods available to detect gas embolism. Clinical signs have both poor sensitivity and specificity, however is readily available. Disadvantages: late signs of VGE only. Observation of respiration has also poor sensitivity and specificity, however is readily available. Disadvantages: high anesthetic concentration is required. Late signs of VGE in spontaneous respiration only. Precordial or esophageal stethoscope have both poor sensitivity and specificity. Advantages includes widely available, cheap, and non-invasive. Disadvantages: requires constant supervision, and there is little warning of CVS collapse. Precordial Doppler, able to detect 0.2 mL per kg of gas emboli. Specificity is moderate. Advantages: non-invasive and is the earliest detector of VGE in most circumstances. Disadvantages: not quantitative, difficult placement, false negatives, and affected by electrocautery. EtCO2 has a sensitivity of detecting 0.4 mL per kg gas emboli. Specificity is, however, poor. Advantages includes non-invasiveness, semi-quantitative, and widely available. EtCO2 plus precordial Doppler offers the optimum combination of sensitivity and affordability. Disadvantages of EtCO2: accuracy is affected by many factors such as cardiac output and COPD. Transesophageal echocardiography is the most sensitive method to detect gas emboli and is able to detect 0.02 mL per kg gas emboli. However, specificity is not absolute. It may detect fat emboli and blood microemboli. Advantages: it is more sensitive and semi-quantitative. Disadvantages: it requires continuous observation. It is invasive, potentially causing glottic injury. It is expensive, cumbersome, may interfere with precordial Doppler, and requires intensive training. CVP has both poor sensitivity and specificity. Advantages: it aids aspiration of air. It is cheap and widely available. Disadvantages: there is risk of trauma. CVL may itself be a source of Venous gas embolism. PA catheter. Sensitivity is fair, specificity is poor. Advantages: it is quantitative and slightly more sensitive than EtCO2. Disadvantages: it may not be widely available in certain centers. Placement for monitoring is not conducive for aspiration of air. It is not specific for air. It is expensive and invasive. Transcranial Doppler have both good sensitivity and specificity. Advantages: it is non-invasive. It enables pre-op detection of patent foramen ovale. Disadvantages: training is required. It is cumbersome and not widely available. End-tidal nitrogen. Sensitivity is 0.1 mL per kg. Specificity is absolute. Advantages: it detects VGE sooner than EtCO2. Disadvantages: it may miss subclinical air embolus. Accuracy is affected by hypotension, and it is expensive. Treatment of gas emboli. For venous gas embolus, resuscitation following principles of ABC should be commenced. Secure airway, administer 100% oxygen, eliminate breathing circuit disconnection. Circulation, check the ECG trace and pulse, employ CPR if necessary. In PAA arrest, chest compressions may be beneficial for treatment of severe hypotension after VAE before cardiac arrest occurs, from evidence of research in animals, as chest compressions force air out of the right ventricular outflow tract into the smaller pulmonary vessels, improving forward blood flow. Follow ALS protocols for non-VF or VT cardiac arrest and cardiac arrest in neurosurgery algorithm. Hemodynamic support with IV fluids and vasopressors. Correct pre-existing hypovolemia. Specific treatments includes prevention of further entrainment of gas or air from entering the circulation, reduce the size of gas emboli, and overcome mechanical obstruction caused by the gas emboli. Methods to prevent further entrainment of gas from entering the circulation. Inform the surgeon of the probable diagnosis and request to flood the surgical field with saline or lactated ringer solution. Apply compression to major drainage vessels, such as with damp packs. Stop reaming. Increase venous pressure to a level greater than atmospheric pressure. Position procedural site below the level of right atrium if possible. For example, position the patient supine or head down. Administer IV fluids. Increase intrathoracic pressure, such as by the use of PEEP, CPAP, or Valsalva maneuver. However, this is controversial. Increased intrathoracic pressure increases CVP, and this may limit the extent and progress of a venous gas embolus. It may decrease the incidence of venous gas embolus and allow identification of the site of air entry. Adverse hemodynamic effects of PEEP, especially in the sitting position, must be considered. 10% of patients may have a patent foramen ovale. Increased right atrial pressure may cause right to left shunt and paradoxical air embolus. Jugular venous compression reduces venous return from the head and increases cerebral venous pressure. The source of gas should be eliminated, for example, by decompressing any gas pressurized system or cavity, such as the abdomen during laparoscopy. Bone wax. Consider asking the surgeon to apply bone wax in exposed bone edges to reduce air entrainment. Reduce the size of gas emboli. Stop nitrous oxide if it is being used, as it will expand any intravascular gas volume. As nitrous oxide is 34 times more soluble than nitrogen, it diffuses rapidly into gas emboli, increasing its size and increasing the negative effects of gas emboli. Give 100% oxygen. Increased oxygen partial pressure in blood and tissue favors nitrogen diffusion out of bubbles and into alveoli. Aspirate the central venous line if one is already in situ. Consider inserting one prior to surgery for high-risk cases. The optimum site for the tip of the CVL catheter is in the right atrium 2 cm below the junction with the SVC. Multi-orifice catheters are more effective than single-orifice ones. Unless the catheter orifice is situated in the airlock within the right atrium, the catheter will not effectively aspirate air. Multi-orifice catheters increases the chance of orifice being situated in an airlock. A specific catheter has been designed which have been shown to be effective in a dog model of venous gas embolism, which is the Bouneguin-Albin air aspiration set by Cook Medical. Pulmonary artery catheter is not effective at aspirating air from gas emboli as its lumen is too narrow. There is no evidence to support the emergency insertion of a standard CVL catheter. Following an unexpected gas embolus, resuscitation should not be delayed to insert a CVL. Consider hyperbaric oxygen therapy if available and the patient is safe for transfer. Increases in ambient pressure reduces the volume of gas emboli. CO2 is the safest gas to use for insufflation of body cavities during surgery. It is non-flammable and more soluble than other agents and will dissolve over time should a gas embolism occur. Priority of management should therefore be to limit the extent and central progress of the gas bubble to minimize its systemic CVS effects. Overcome mechanical obstruction caused by the gas embolism by placing the patient head down in the left lateral position. This is a classical teaching. The purpose is to keep the bubble in the right atrium or apex of the right ventricle until it dissolves, or can be aspirated via a central line advanced into the right atrium. However, there are no evidence in humans or animals to support putting the patient in left lateral position to shift air to the non-dependent parts of the right ventricle and to reduce outflow obstruction. Positive inotropes increases cardiac contractility, cardiac output, and systolic blood pressure in the face of increased pulmonary vascular resistance. A bolus dose may be required. Cardiopulmonary bypass is life-saving, especially in massive gas embolism. Surgical removal of gas embolism may be possible, for example, directly from the pulmonary artery at thoracotomy. Transthoracic ultrasound can be used to confirm the diagnosis and guide treatment. Perform 12-lead ECG to look for ischemia. Air in coronary arteries is suggestive of paradoxical air embolism. Treatment of arterial gas embolus. Resuscitate following principles of ABC. Prevent further entrainment of gas from entering the circulation. Remove the source causing arterial gas embolism. Hyperbaric oxygen therapy is the treatment of choice. Tissue hyperoxia results in large pressure gradients for oxygen to diffuse into and nitrogen to diffuse out of the gas emboli, and also increases oxygen delivery to ischemic tissues. Anticoagulation, corticosteroids, and IV lidocaine not recommended. These are my references. Thank you.